is quite a relatively young patient. He's a male, 68, presentation with dyspnea. He has history of hypertension, dyslipidemia, diabetes, non-insulin requiring, but the main problem is the morbid obesity, and this is probably the reason why he's here with us. He also suffered from coronary artery disease. He had received a PCI in another hospital in 2018 and 2022. Unfortunately, I don't have these angios to show to you today. And also he has suffered from some episodes of paroxysmal atrial fibrillation. And this is the reason why he was under anticoagulation. Next. So the ACG is normal on the sinus rim at 63. Blood test is quite normal with a little bit high urea and creatinine in borderline. The body mass index is 44, and the echo Doppler unveils severe aortic stenosis with area of 0.9, with a gradient of 56 and 34, the same gradient which was measured recently here in the lab. He has a preserved left ventricular ejection fraction with 55 as a ejection fraction. He is not frailty. He has a not frailty, and he's not fertile for this procedure. Next. So this is the angio CT. The diameters are 26 and 29 with a perimeter of 87, with the area of the annulus of 602, sinus of Valsalva diameters of 34, 36, and 37. So it's a huge aorta with the big annulus 2. The coronary ostia height is close to 19 for the left and 20 for the right. So they are quite high. We have some annulus in below the left coronary cusp extending into the LVOT. This is something to be considered, especially for predilatation. We are not going to be too aggressive. This is a tricuspid valve. We also have probably 90 degrees of calcification on the sinotubular junction, but where the diameter is about 26 in average. So this is the valve, which is tricuspid with a significant calcification on the 3 leaflets, and this is the reason why we have decided to pre-dilate this patient before. Next. This is the coronary height for the left coronary ostium is 19, for the right is 20, and for the non-coronary cusp, the height is about 24. So this is important, this height, because we are going to try, and I will show you one slide, that to be with the valve below the sinotubular junction to prevent any kind of dislodgement or detachment of this calcium, which is there. Next. This is the aorta, and this is another important issue. There is not a significant calcification on the ascending aorta or in the aortic arc, but this quite significant angulated aorta. You see that the angulation of the annulus in relationship with the ventricle is close to the 60, almost in the borderline for the self-expandable valve, and this is one of the reasons why we have decided to go today with the balloon expandable valve. This is our implanter's view that we regularly use for almost all valves, even for balloon expandable. We also use cusp overlap view for the implantation. In this patient, it's going to be on right 1 degree on caudal inclination of 15 degrees. So this is the aorta. Quite straight femoral arteries with some calcification on the iliac arteries and in the abdominal aorta. Next. So this is the femoral access. We have chosen to go by the right. This is a huge artery. The common femoral artery is 7/9. We are going to use this expandable sheath from Edwards. For the valve 29, we had to use this 16 French. So we need a minimum of 6 millimeters for the iliac artery. But in this case, we have a huge artery. This is not something to be worried about it. This is the left side. It's also possibly side for access, but we have chosen, as usually, the right if it is possible. So in summary, it's a very young patient with, not very no, but a young patient with severe aortic and symptomatic aortic stenosis. And the team discussion where Dr. Fava was, they considered that, according with the surgeon, that he is not a good surgical candidate due to specifically a morbid obesity and this huge body mass index. So you might see him on the table. He's occupying all the table, and I will show you some difficulties related with that. So our plan today is to implant the TAVI. I told you this is going to be a balloon expandable valve, especially due to the angulation. And the strategy is to go femoral access as always. In this case, we have chosen to predilate. We are going to use not a big balloon, and it's going to be a 20 millimeter balloon probably. So according to the area, I have already mentioned, we have measured 620. So for the sizing, for the Sapien 3, we have considered these possibilities. We have, of course, chosen the 29, and we have different options to go nominal. It's going to be 4% of oversizing. With 1 cc, it's going to be 7, and with 2 cc, it's going to be 10.6. So we have chosen to go 2 cc more than nominal for this case. So here is the valve when it's crimped. The height of the valve, of the length of the valve is 30, but after the full dilatation, it's going to be 24, with probably 11 or 12 up the annulus, above the annulus, another 8 millimeter below the annulus or intra and below the annulus. So we have to manipulate the valve to go not too deep, but not too high, trying to not to touch this calcification on the sinotubular junction, which was shown before. So we have this central market, and the idea is to go probably 3 millimeters below, but if we see that the valve is touching the sinotubular junction, we can go probably 1 millimeter below just in case. So let's go back to the real life. We have already done. We have done the puncture on the left common femoral artery. So probably we can show you the angiography also too. We have a venous access here, and we have a crossover with the over-thin wire as always. And we have decided to go with the 2 proglides. And then probably we close the first one under the 6 French sheath. And if everything is okay, we continue with the 2. But if we have important bleeding, we can consider to put an additional angioseal.
We already done the echo, so there's no effusion and pelvic function is normal. So this is what we do usually, first an echo to see that no effusion is present.
So here, when we have a very long distance, it's important you don't have a kinking before entering to the artery. So here I'm sure I am in. So I will open and retrieve it, rotate, and let's go with the first. And then we are deploy the second. But you know, it's amazing, but the distance was almost not enough to get into the artery due to this huge amount of adipose tissue we have here. So we will introduce again the wire to introduce the second proline. Dr. Mukarsel, how is the ventricular function in this patient? And if the gradient is the gradient that we had before?
We have 64 of peak gradient here, about 4 meters per second velocity.
Okay. So Carlos is attaching the introducer with the sheath because they are not fixed. And sometimes you can damage the artery if you lose the position. Now we are going to cross the valve. We will try to go as usually with the pigtail. If we can't, we go with the regular way of using amplatz catheter and a straight wire. Not that easy to see due to the morbid obesity, such a huge thorax. So now I have a shade wire there. I have the pigtail. Well, if you take the time, you are not rushing, usually you can cross. Probably in 80% of the cases, you don't have to exchange, you don't have danger to stick the ventricle wall with the straight wire. So now we are going to position in the contralateral pigtail. We have configured wire here. As always, we try to reshape, especially for small ventricles, to make it smaller as I can. So here in the camera, you can see that we have downgraded. Now it's probably, this is my finger, 2 millimeters, 2 centimeters. And then one additional shape here, especially in this case for very angulated aorta. We are going to base him from the wire. We will test during the predilatation. If we don't like it, we can introduce a pacing catheter into the right ventricle as usually. So let's go with the balloon. We have prepared a 20 millimeter balloon. So it's smaller than the sinotubular junction. And we can prepare the valve for crossing and then to valve implantation. Then we are going to paste in 180 on, yes. Let's go, Carlos. It was not expected. Give me the pacemaker, please. Oh, we have to change the strategy. That's why we have this introducer. We are going to change
the introducer.
The introducer set, and we are going to put the pace. Quite unusual because it was an 18 millimeter balloon with a big annulus. We haven't touched too much. So to be honest, I didn't expect something like this. Okay, leave it at 40. So there we have his own rhythm. Perfect. So valve is out. Everything is okay. He is in the up. So we are unlocked. Carlos is gonna push the wire. I'm gonna positioning the balloon into the valve until the mark. Okay, here is the mark. This is the mark. It's okay. Now we have to go to the fine adjustment. We are going to introduce the balloon in. So it's so big, the patient, that the image we have is not that good. Patient is too long. So we are going to deflect the catheter for the aortic arc. And we are almost in. Okay. We can wait there. We can reposition in the pigtail, which I think is twisted with the valve. And I will need the Amplatz wire to go into the sinus. So now they are not twisted. The pigtail is in the right position. And I have to go a little bit deeper with the valve. Will you test? Okay, throw a little bit higher. Do you agree? But not too much. Let's go with Cine. Cine. We are in the middle of the pigtail with the mark, no? You want a little bit higher? Okay. Okay, probably there. Test. Okay, I will put here. Little bit higher. Okay, so pacing, test. Let's go, Carlos. 1, 2, 3, 4, 5, deflate. Okay. Okay, stop pacing. We have ventricular tachycardia. Let's reversion, please. Okay, please, norepinephrine. Patient is hypotensive. He's recovering.
Sí. No.
Give me the Amplatz wire. This is a very unexpected situation again. This is when the team is ready for everything. We have to be prepared for everything. Can happen at any moment. This is interventional cardiology. So I think the position is okay. It's almost perfect because on the non-coronary cusp is probably a 3 and probably 4, 5 on the left. Diastolic is now, well, the patient is still hypotensive, but I think we don't have to post-dilate anymore. Dr. Murkastel is going to check because if we have a good outcome, I don't like to overstimulate again this patient.
So let's take a look. Just a sec. So LV function is normal. So we have good ejection fraction, no effusion at all.
Will you check the gradient and regurgitation?
Yes. So we have normal gradients. Gradients are 14 and 7.
Okay.
And so far, no leak at all.
Okay, so we can pull this delivery system out and we can introduce the pigtail, we can do an ansio, we can measure the gradient, and then we can decide what to do. I would extract the delivery system, I will pull everything out. You see that on the fluoro, that what we try to do is not touch the sinotubular junction. The valve is exactly below. So here we have the gradients. Let me go with zeros. Okay. We had a good notch that there. The diastolic is not that, probably not too high, but the curve is okay. The blood pressure is 100 now. Probably we still have to give some norepinephrine or something like this. We will do an ansio 25 probably because he's too big to see what is going on. It's exactly according with the Dr. Mukarsel's findings. No gradient, no regurgitation at all. I think the position is okay. Probably 1 millimeter deeper than I like it, but it's okay. So I think we are finished here. We can pull this pigtail out. So I will show you in the monitor how is the rhythm now. Let me show you. So you see the patient is under probably complete AV block with some rhythm, but with the complete AV block. So we have to wait. We don't have to rush to put the pacemaker right now, but this is probably a patient who might need it, even though it is a balloon expandable valve. But you know, the conduction disturbance appear after predilatation. So it's totally unexpected. So we will try to close the groin. First, we try to reintroduce the introducer set for pulling the sheath, but I will connect to pressure with this on the other one. Here, I will pull the sheath, introduce the 6 French, and then I tie the knot. But before, I'm going to go contralateral, just in case.
No, LV looks right. No diastolic dysfunction. The feeling looks good.
So probably
RV normal. No effusion.
Okay, the suture was broken, probably because the depth. We are now using only one. With only one, we are almost okay. But for sure, we have to use the angioseal. We also have to exchange for the balloon. Give me a 9mm or 8mm balloon. So we are going contralateral and we inflate the balloon there. And then we hold the groin for minutes. So now it seems to be better. We have some oozing, you see with the camera here on the groin, just some oozing, but I will check it and I will inflate the contralateral balloon for some minutes to get the perfect sealing. So the sealing is okay. So we can hold it, move it, light. So I will tight all the knots and we'll cut it. Okay. Carlos is gonna hold the balloon and we can hold the groin. Yeah, the blood pressure is 100. We will hold the groin to get the perfect sealing. We will test once more to be sure that it's, we don't have any kind of bleeding. And then we will leave the wire in the right ventricle for pacing. And we will call our colleagues to keep this patient in mind and to decide probably tomorrow morning to put the pacemaker if this conduction disturbances does not disappear in the next 12 hours or something like this.